Welcome back, fellow mitochondriacs, to another episode of Cancer as a Mitochondrial Metabolic Disease. This is our second attempt at doing this because the first time did not have any sound, it didn't look like, for the audience. So I'm going to let someone log in and hopefully tell me that we have sound. But until I get a little bit of feedback from you all, I'm going to talk about the management of cancer potentially using alkalinization therapy. And I am, kind of taking a quick break from looking at the inhibition of glucose and glutamine as a way to kind of urgently get you this information. Good. Okay, I'm getting feedback that everybody's hearing me, so that's good. I don't know what happened the last stream. Sorry for the inconvenience. So while I've known about this for quite some time, I would say that I was somewhat skeptical in the early pieces of looking at these. I don't want to say claims, but this strategy, this therapy. But the more that I understood about the importance of the lactic and succinic acid tumor microenvironment and how it ultimately led to treatment failure and all these other things, which we'll discuss in detail. And then I started seeing outcome data about how it was affecting patients. And I was seeing how easy it was to detect, track, manage on the fly. It seems that it would have been better to share this sooner than later. I also want to say that, my position as a hospitalist doctor, I have been seeing, one of the things that we pretty much always order on a patient coming into the hospital is a UA or a urinalysis. And I've been trying to have more awareness at looking at the urine pH from the patients that I admit with cancer. And I have to tell you that I'm seeing that the majority of the patients will have a low urine pH, signifying that they could highly benefit from these type of therapies now that I'm seeing the literature. So I wanted to divulge or I wanted to take a detour from our kind of normal flow of things. We're talking about glucose inhibition and in particular glucose transporters. And I still have, more to share on that, which I will share later this week. But I wanted to bring this to you kind of sooner than later because I think it's important. So without further ado, let's get into what I have prepared. So I'm going to start out by talking about kind of what we're up against and why. Now, I have a whole kind of micro series on lactic acid or lactate. And there are several videos at the beginning of the Cancer as a Metabolic Disease series, probably like last April, May timeframe. And that will help us, understand where it comes from and why it's a big deal. But I'm going to do a little bit of a mini crash course at the beginning of this for those who had not seen that and are not aware of the tumor microenvironment and the acidity of that tumor microenvironment. So this paper is titled Tumor Acidity from Hallmark of Cancer to Target of Treatment. And it says tumor acidity is one of the cancer hallmarks and is associated with metabolic reprogramming and the use of glycolysis, which results in high intracellular lactic acid concentration. Cancer cells avoid acid stress I'm guessing they meant major acid stress, by the activation and expression of proton and lactate transporters and exchangers, and have inverted pH gradient. Extracellular and intracellular pHs are acid and alkaline, respectively. The shift in tumor acid-base balance promotes proliferation, apoptosis avoidance, invasiveness, metastatic potential aggressiveness, immune evasion, and treatment resistance. Later on, I'd highlighted that another idea is the oral or parenteral use of buffer systems such as sodium bicarbonate to neutralize tumor acidity. Buffering therapy does not counteract standard treatment methods and can be used in combination to increase effectiveness. So I wanted to set this up that, number one, this is a big problem for both unconventional and conventional oncology. It's really a big problem. Number one. Number two, they are looking at simple strategies in a lot of cases to enhance the standard of care. And I think that's pretty interesting. So going further into the paper, I really wanted to give you a little more detail, which is why I didn't read the entire abstract. This is from inside the paper. Tumor acidity as a hallmark of cancer. One of the causes of tumor heterogeneity is altered volume tumor vasculature, which leads to different perfusion of nutrients and oxygen and to the accumulation of acidic metabolites. Due to the reprogramming of metabolism in such conditions and the use of glycolysis as the major source of ATP production, tumor cells have an acidic pH of 6.4 to 7.1, but can vary. So what I think they're saying here is the extracellular pH, pHe, is 6.4 to 7.1, and the alkaline pH interior, 7.1 to 7.8. For normal tissues, the pH is 7.4. Inside the cell is 7.2, and outside the cell was 7.4. Large amounts of lactate produced during glycolysis result in significant increase in intracellular proton H+ concentration. It should be noted that glutaminolysis is another way for ATP production and an additional source of lactate and H+ in cancer cells. What I'll say is that I don't know if that's necessarily true. Definitely glutamine can be a source of ATP and a source of H+, but it's not making lactate. It's actually making succinate, which we'll see in later graphics. I just want to clarify that. In addition, glutamine uptake and metabolism in oxidative cancer cells can be promoted by lactate. That is true. Lactic acid can cause glutamine to be utilized through the stabilization of hypoxia factors and all the things that it can do once it's stabilized, including the uptake and utilization of glutamine. That is true. However, even the presence of oxygen, glucose is almost utterly converted to lactate. True. At the same time, glutamine is not fully respired, but it is rather fermented into lactate. Where they're wrong here is it's not lactate. It's actually succinic acid or pyruvate. Increased glutamine flux can enhance aerobic glycolysis and make it optimal for tumor proliferation. Later, it says acidosis of the tumor microenvironment is an essential stage associated with high rates of tumor cell proliferation. Numerous studies have shown a role of tumor acidity in acquiring aggressive cancer characteristics, so it is recognized as a hallmark of cancer. For example, melanoma cells exposed to acidosis are characterized by a highly invasive potential, high resistance to apoptosis and drug therapy, fixed independent growth, and phenotype of epithelial and mesenchymal transition. Under growth factor limitations, alkaline pHi favors cancer cell survival. The acid adaptation of tumor cells leads to the gene expression response and characterized by human tissue gene expression profiles and survival. I'm going to stop here and I'm going to take a breather and kind of explain what I'm understanding of what it's saying here. So number one, the physiologic pH of humans is somewhere between 7.35 and 7.45. If you did an arterial blood gas or a venous blood gas, that's what we're going to be looking for as normal pH in the serum. However, from normal tissues outside the cell, the normal is 7.4. Inside the cell, pHi is about 7.2. However, because of the Warburg effect and because of the aerobic glycolysis, we are making a bunch more lactate than we would be normally. So let me use a graphic to explain this. So normal cell, let's say 1x glucose utilization, turning into pyruvate through glycolysis, being oxidized through the TCA and oxidative phosphorylation system within the mitochondria that are intact. There is little or no lactate being made. As you can see, there's no arrow to lactate. However, under cancer metabolism, glucose is being utilized 10 to 30x more than a normal cell. And a big percentage of that glucose is being fermented into lactate. Lactate, or lactic acid, is acidic. And so what happens is, as it says here, well, I'm not sure exactly where it said it, but there's an upregulation of transporters. Actually, I think it was in the abstract. There's an upregulation of transporters and exchangers that basically will, these exchangers like this, will take that lactate and it'll put it outside the cell. And what they're saying is that there's a relative alkalosis inside the cell. And it says here that the pH of these cancer cells on average is 7.1 to 7.8. So physiologic pH all the way up slightly higher than physiologic pH, 7.8. Whereas the outside the cell, because the lactate is being shuttled outside the tumor into the tumor microenvironment, the lactic acid and succinic acid will lower the pH outside the cell. And as a matter of fact, it's lower than physiologic pH, somewhere at 6.4, which is very acidic compared to normal pH, upwards of 7.1, which is still lower than physiologic pH. So that's what it's saying here. It's also talking about glutamine, and glutamine, again, here is being brought into the cell, and it's going to be taken out as succinic acid. We're going to talk about this in greater detail, but I do want to get through this paper, at least a couple parts of this paper, so we can set the stage up for why this is even necessary to talk about alkalinization of a patient. Later on in the paper, it says acidic tumor microenvironment, or TME, itself can lead to chemoresistance due to ongoing physiochemical changes and structure and charge of drugs. Weak base chemotherapeutics such as vincristine, mitoxantrone, doxorubicin, vinblastine, and paclitaxel may have substantially reduced cellular uptake capacity due to neutralization or proteination, ion trapping. Therefore, the cytotoxic effects of these drugs for the target tissues, right? So there's still cytotoxic effects to the normal tissues. So that's why you're going to have more side effects for the non-cancer cells, because they're able to get into the cells just fine. Whereas the cancer itself is resistant because these chemotherapeutics are weak bases. So therefore they get eaten up by this acidic tumor microenvironment. We'll show some pictures to kind of further look at this, resulting in a stable tumor phenotype. Interestingly, reversing the pH gradient may increase the intracellular concentration of some weak acid drugs, including cyclophosphamide and chlorambucil. Acidic tumor microenvironment induces P-glycoprotein multiple drug resistance protein activity and promotes P38 mitogen activating protein kinase. Tumor acidosis induces the expression of transcription factor SOX2 and by inhibiting vitamin D receptor mediated transcription. Interesting. Which also results in drug resistance. Oxidation induced lactic acidosis increases resistance to this uprocetab, a serine threonine protein kinase inhibitor in colon cancer cells. To obtain the maximum effect of chemotherapy, the acidity of the tumor microenvironment must be considered. So what this is essentially giving us is multiple examples of both kind of more novel cancer medications, like this monoclonal antibody here, this serine threonine protein kinase inhibitor, or older drugs like vincristine, vinblastine, doxorubicin, paclitaxel, etc. And they're showing that this tumor acidity, or the extracellular tumor microenvironment, is decreasing the effectiveness of these particular treatments. Later on, in the conclusion, it says, despite extensive studies on the acid-base status of malignant tumors over the past decades, the mechanisms of tumor adaptation to acidity, induction of invasive and metastases, and the mechanism leading to an invasion of the immune system surveillance are still poorly understood. Further research in this direction is needed, including development of approaches and drugs that directly or indirectly increase pH of the TME for use in conjunction of chemotherapy, radiation therapy, and immunotherapy. I'm just going to stop there. So this is a problem, okay? And the mainstream medical community is seeing that this is a problem for all of the new therapies, whether it be chemotherapy, whether it be radiotherapy, whether it be an immunotherapy or targeted therapies, because these therapies either rely on getting into the cells, which they can't because they're weak bases, or they're relying on the immune system, in the case of immunotherapy, to be activated, but the immune system is inactivated by the tumor microenvironment. So the lactic acid and the succinic acid tumor microenvironment is a big problem for us. All right, let's go back quickly to Warburg physiology here for a second. So remember, these Warburg cells, okay, they have fundamental mitochondrial defects that allow them to not be able to make ATP through mitochondrial respiratory electron transport. In addition to that, there's some key things that are being set up to actually block these mitochondria from being able to work. Number one, hypoxia-inducible factor 1 alpha, which is driving Warburg metabolism, will essentially remove mitochondria in excess through excess mitophagy or mitochondrial associated autophagy, number one. Number two, it will shut down the electron transport chain at complex 1, number two. Number three, there is a protein that will be upregulated called pyruvate dehydrogenase kinase, which will stop pyruvate from getting into the TCA cycle, into the mitochondria, and functionally shut down the mitochondria from several different steps. Okay, so what we're left with is a salvage pathway where we're fermenting glucose and we're upregulating these glucose transporters and all the machinery necessary to take glucose and turn it into pyruvic acid and later lactic acid. What was talked about in the prior paper is because lactate is acidic, it gets taken outside the cell through these transporters, these lactic acid transporters and proton transporters, et cetera. And lactic acid is then put into the extracellular environment. Okay, that's called the tumor microenvironment. Again, normal cell, you don't see a lactic acid arrow, okay, unless you're doing a sprint or some kind of high intensity interval training, or unless you were, drowning or something like that. So therefore, the majority of the glucose, and remember, it's much less glucose because these normal cells are metabolically flexible. They're using oxidative phosphorylation. They are efficiently using respiration and mitochondria. Cancer cells are not. Remember, we talked about PDK, pyruvate dehydrogenase kinase, that's blocking pyruvate from getting into the TCA cycle, and that's under the control of hypoxia-inducible factor, HIF. Needless to say, lots of glucose being made into pyruvate. Pyruvate is being made into lactate. Lactate is being transported outside the cell. Let's look at this from a different perspective. Hypoxia-inducible factor, which is what is leading to the Warburg effect. The Warburg effect, the end product of the Warburg effect is the lactic acid. The acidosis will then lead to ion trapping, like I said in that paper, where it leads to chemotherapy resistance, and it leads to immunoresistance as well. This is another paper, lactate and the regulation of tumor microenvironment and therapeutic approaches. And it shows here that this lactate, and I would also dare say succinate, creates the acidification of the tumor microenvironment. It leads to the suppression of our immune system. It leads to metastatic spread, chemotherapy, immunotherapy, resistance, and potentially can provide some fuel, which although Dr. Seyfried does minimize that being important, because of reverse Warburg metabolism, which I have not really talked about, but I don't think it's that big of a deal. And then what I wanted to also show before we moved on to what the actual protocol or process would be and clinical outcomes, which are very important, is looking at how glutamine, when it is metabolized, will make succinate. And this becomes another area of vicious snowballs, because the lactic acid will stabilize hypoxia-inducible factor, which will upregulate glutamine uptake and utilization. Then when the succinic acid is fermented, succinate will also stabilize hypoxia-inducible factor, which leads to another arm of the vicious cycle. And then the succinic acid also contributes to the tumor microenvironment. This is a slide from one of Seyfried's most recent papers. And I think it's a really beautiful illustration of really, number one, the metabolism that's going on within cancer cells, but also the where metabolic therapy is kind of working upon. So again, glucose is fermented to lactic acid. Okay, lactic acid acidifies the extracellular microenvironment. It does have a lot of other stuff too, which we've talked about at length in the past, whether it be ATP, whether it be fatty acids or amino acids or the PPP or glutathione production, etc. Glutamine also makes ATP through the fermentation to succinic acid, but it also is responsible for other proteins, other amino acids, fatty acids, and of course, glutathione. And when we block glucose and glutamine, we essentially shut this process down. But that's not what we're talking about here. We're talking about the extracellular tumor microenvironment, and that's made up of succinic acid and lactic acid, both from glucose and glutamine. So the acidosis is a big problem for us. This paper was published just fairly recently, September of 2024. And it says here that how does cancer occur? How should it be treated? Treatment from a perspective of alkalinization therapy based on science-based medicine. And it says here that this review article investigates the relationship between mitochondrial dysfunction and cancer progression. That's a good start. Emphasizing the metabolic shifts that promote tumor growth. Mitochondria are crucial for cellular energy production, but they also play a significant role in cancer progression by promoting glycolysis under oxygen-rich environments, a phenomenon known as the Warburg effect. This metabolic reprogramming enables cancer to maintain an alkaline internal pH in an acidic external environment, which is critical for the proliferation and survival in hypoxic conditions. I just want to step back for a second and say that other than this graphic here and this paper published by Seyfried just recently, and gosh, when was it? I think it was December 2nd of 2024. Almost all of these papers that we're going through today do not have Seyfried as an author. So this is pretty well established across, oncology research. Again, you can see Seyfried is not, this looks like a Japanese maybe group. So these papers are, from multiple groups throughout science, and they're all using the same vernacular. They're looking at the same problem from a different lens. The Warburg effect is a hallmark of cancer. The acidic tumor microenvironment is a hallmark of cancer. So I just want to let you know that this is not really siloed information. This is well established in multiple publications over years and years and years. So I just want to leave you with that little tidbit for a second, because I know that can be a little bit worrisome for some people, that this is one author having one point of view and kind of having an echo chamber, I guess you'd say. And this is not what this is. Okay. Getting back on point. So this article also explores the acidic tumor microenvironment, TME, a consequence of an extensive glycolytic activity, or the use of glucose for energy, and proton production by cancer cells. The acidic milieu enhances the invasiveness and metastatic potential of cancer cells and contributes to the increased resistance to chemotherapy. We've talked about that. Alkalinization therapy, which involves neutralization or neutralizing the acidity through dietary modification and the administration of alkalizing agents such as sodium bicarbonate, is highlighted as an effective strategy to counteract these adverse conditions and impede cancer progression. Integrating insights into science-based medicine, the review evaluates the effectiveness of alkalinization therapy across a variety of various cancer types through clinical assessments. Science-based medicine, which utilizes inductive reasoning from clinical observation outcomes, lends support to the hypothesis of metabolic reprogramming in cancer therapy, both addressing the metabolic and environmental disruptions. This review suggests that considering cancer as a primary metabolic disorder could lead to more targeted and effective treatment strategies, potentially improving outcomes for patients with advanced stage cancer. So what I have to say is I'm very encouraged by just the way they've written this abstract. Okay, these researchers that, again, I would guess by the last names, are in Japan, are on board. Okay, they're getting it, and this is a very recent paper, September of 2024, right? So I do think that there is, I'm hoping at least, and this could be wishful thinking on my part, but I'm hoping that there is a paradigm shift that is occurring. The issue is that it's not occurring fast enough for people who are already stricken with these diseases. So therefore, I think that things like this need to be really streamlined to the front lines quickly, because as you're going to see as we go through these papers, the data is pretty convincing. Okay. And I do believe this to be probably one of the easiest, safest, and cheapest therapies that there is. So therefore, and it enhances conventional and it enhances metabolic therapy. Now, I will say, before we go on to, the publications, I want to present with you this paper that was published by Seyfried, believe it or not, as well as Duraj and Dom D'Agostino and others. So this paper was published in Frontiers of Oncology in August of 2022, so fairly recent. And what they're saying is, and it makes a lot of sense, because we'll go back to the graphic, but the simultaneous restriction of glucose and glutamine, while elevating non-fermentable anti-inflammatory ketone bodies, can help restore the pH balance of the microenvironment, while at the same time providing non-toxic therapeutic strategy for killing most of the neoplastic cells. So what he's actually saying, or what they're saying in this paper, is that when we are on a therapeutic ketogenic diet, okay, let's say we take care of the glucose part of it, or at least part of the glucose part of it, and we introduce some glutamine blocker, whether it be a glutamine uptake inhibitor or a glutamine utilization inhibitor. Let's just use what Seyfried talks about a lot and what it's also listed in this paper, right? We see it here, Don, right? We will effectively collapse the tumor microenvironment, because glucose that was normally being in high amounts fermented to lactate is now stopped. And the glutamine that was being utilized to make succinic acid has now effectively stopped. So therefore, the acidic tumor microenvironment is handled by a large degree by metabolic therapy as a whole. So the reason I put this paper smack dab in the middle of this talk is because this strategy, which makes a ton of sense and likely is effective by itself, is not talked about by any of the subsequent papers. So therefore, I wanted to leave you with that bit of information, because I do believe that if you're on a ketogenic diet by itself, you're taking care of some of this. If you're on a ketogenic diet and you're on 2DG or some other glutamine uptake or utilization inhibitor, you are taking care of this, at least the lactic acid side of things. If you are taking some glutamine uptake inhibitor or DON or something else, you are taking care of part of this already. Okay, I want to let you know that you're already effectively doing that. Now, is it enough? That is to be determined, and that is to be tracked to know whether it's enough. But I'm going to digress and move forward here. So I first kind of got wind about this being a thing by looking at these papers, this paper here and this paper here. And what they were finding And this paper was published in 2021, so it's fairly recent. Neutralization of acidic tumor microenvironment with daily oral dosing of sodium potassium citrate increases therapeutic effect of anti-cancer agent in pancreatic cancer xenograft mice model. And it says here, neutralization of tumor microenvironment, acidic tumor microenvironment, by alkaline substance like bicarbonate, an active metabolite of potassium sodium citrate, well potentiated therapeutic effect of anti-cancer agents, an orally active 5 full fluoro uracil derivative in PANC1 pancreatic cancer xenograft murine model. Neutralization of acidic tumor microenvironment using alkaline K potassium sodium citrate is a smart approach for the enhancement of therapeutic effects of anti-cancer agent for pancreatic cancer in the end stage. Why we want to wait for the end stage, that I don't understand. But that's what they were saying in this paper. I later saw this paper, which was published a year later in October of 2022. It says oral administration of sodium bicarbonate can enhance the therapeutic outcome of Doxil via neutralization of the tumor microenvironment. And it says here that I'm just going to read a little bit more than I had highlighted. The pH of the tumor microenvironment in solid tumors is reported to be more acidic than normal tissues. This we know. The pH is controlled by overexpression of several transporters that are associated with the progression of cancer, angiogenesis, the making of new blood vessels, and the metastases of solid tumors. Anti-tumor effects of weak-base anti-cancer agents such as doxorubicin could be reduced in an acidic environment because an increase in ionized form of the drug under these conditions, reducing membrane permeability. So therefore, this medication, this chemotherapeutic medication, gets eaten up in the microenvironment and it cannot get into the cancer cell like it's supposed to. So that's a big problem, right? It's going to affect the normal cells, but it's not going to affect the cells that we actually are injecting this drug for. So in our previous studies, we demonstrated that oral administration of sodium bicarbonate can neutralize the tumor microenvironment and enhance the effect of small molecule anti-cancer drugs. So this is what kind of like got me my ears kind of like perked up a little bit, right? I'm like, okay, this is actually kind of an interesting thing. Like I had been studying Warburg metabolism enough to know about the lactic acid tumor microenvironment. I had known that lactate was causing immune suppression and metastatic dissemination and therapy resistance, but I didn't understand why until I read this paper. I'm like, oh, these chemotherapeutic medications are weak bases and they can't get into where they're supposed to get. So that leads to tumor, progression, or maybe having to use higher doses of the chemotherapeutic agents, but we're then having more side effects because it's getting into the normal cells, but it's not getting to the cells we want. So like I could see this being a big problem. And I could see that medicine, mainstream medicine was saying, okay, like we need to have a target for this. And the use of sodium bicarbonate seems to be a simple strategy for this. Okay. Now I can tell you, just taking a quick digression here, I can tell you that, alkalinization therapy, not to, be derogatory, but I'm going to use, the hippie like vegans, right, have been talking about alkaline diets forever, right? And what has medicine been doing? It's been effectively, I mean, they're going to do it no matter what you do outside of the standard of care, to be fair. But they've been basically, oh, that's complete garbage. Like, you're not doing anything for yourself. Like, there's nothing to do with acid alkaline diets. Like, there's nothing to do with that. Well, that seems to be complete nonsense. It seems that there is something to this, and we're going to see it. Okay, in these next slides. Okay, in terms of clinical outcomes, and we're going to see that there probably is value to a more alkaline diet. Does that mean that we're going to be on a fruitarian, high carbohydrate diet? No, I think that would be irresponsible, in my opinion. That being said, could you add some alkaline plants and vegetables, probably non-starchy ones that have high fiber and can lower your blood glucose, in combination with a ketogenic diet as a way to help yourself? Very likely, and you're going to see that. I'm going to look at some of these comments just real quick here. Should I add sodium bicarb to the starve kill therapeutic weeks? We're going to talk about that in a second. Hi, doctor. Earlier you were talking about importance of recycling and removal of the pathogenic substance from the tumor microenvironment for therapeutic effects. But do you think apoptosis of cancer cells during treatment would additionally acidify the tumor microenvironment? Great question. Hold that thought for a second. Treatment with press pulse phase of press pulse. Greetings from Germany. Greetings from Florida. So going back quickly here, do you see here how it says radiation therapy is leading to decreases in the pH here? So although I don't know that to be completely true, it seems that that may be true. That, to answer your question more directly, do you think apoptosis from cancer cells during treatment would additionally acidify the tumor microenvironment? I think by looking at this slide, I think it's possible. I don't think apoptosis as much will as necrosis, right? See this, you don't see it here, but you see the word necrosis here. That necrosis may lead to escape of succinic acid and lactic acid, which may acidify further the tumor microenvironment. So I do think that necrosis could from some things. Do I think apoptosis probably does not? I know that's kind of like maybe a little bit of a, oh gosh, I can't even think of the word. It may seem like tomato, but I do think that those two different ways that cells are dying probably does matter. But I'm going to digress off of that. So let's look into outcomes. Okay. I'm going to go through some history of what we got. Okay. Do we have enough studies? Do I think that there needs to be more studies like this on other types of cancer, bigger studies? Absolutely. But what we got is pretty convincing. Okay. So the first paper that I could find was published in Anti-Cancer Research in February of 2020. And it says the effects of alkalinization therapy on chemotherapy outcomes in metastatic or recurrent pancreatic cancer, known to be a horrible cancer, right? So they took 28 patients with either recurrent or metastatic cancer. They gave them an alkaline therapy, which included an alkaline diet, quote unquote, which we'll kind of look at what they mean by that in further studies because it kind of further elucidated. And then you're getting supplemental sodium bicarbonate 3 to 5 grams per day, which is kind of a lot. I'll be very frank with you. I'll talk about this later on, but from my experience, we use sodium bicarbonate a lot in medicine, mostly in the area of medicine of nephrology or kidney medicine for people who can't manage their own alkaline-based status. They may have like a chronic metabolic acidosis from chronic kidney disease or end-stage renal disease. And we give people sodium bicarbonate tablets a lot. They usually come in tablets of 650 milligrams, and we usually give like 3 to 4 per day. So, that's quite a bit lower than 3 to 5 grams per day, but I'll digress. The mean urine pH was significantly higher after alkalinization therapy. Imagine that. Now, I want you to remember this and burn this into your brain. The average pH of urine for this alkaline group was 6.85, okay? Versus the normal people who were not getting alkaline pH or alkalinization therapy, their urine pH was 6.339. Not a huge difference there. But the overall survival was 16 months. Again, still terrible, right? Like 16 months for someone who has metastatic cancer. But if you didn't alkalinize the urine, it was 4.7 months. This is a nearly 4-fold increase in survival with a minimal difference in urine pH. Okay, so this is pretty astounding. And you're going to see that this is not unique to this particular study. Let's keep going. The next paper published, So this paper, where they had 89 patients, 36 were in the alkalinization group, and 89 were in the control group. Okay, and the mean overall survival time was significantly longer in the control group and in the alkalinization group versus the control group. And this one, they had 15 months versus 10 months. Okay, so still an extra, nearly 5 months of survival. But I'm going to highlight this. Look at the difference. The urine pH for the control group was 6.38, okay? and 6.8 for the alkaline group, okay? So you're getting an extra 5 months in this paper and an extra, 12 months in this paper? Nearly 12 months in this paper by going from 6.39 in this paper to 6.85. And in this paper, from 6.38 to 6.80. Okay. I want to burn those numbers in your head. Okay. Because what we're starting to see is that higher is better. And so what I'm saying is that we got a significant benefit from a minimal increase in urine pH in terms of months of survival with these horrible cancers, despite a minimal and likely subtherapeutic dose of pH. Okay. Going further, this is a small cell lung cancer group. Again, unfortunately, this has got a little bit of a confounding variable. Okay. So they did alkalinization therapy with IVC. So the mean urine pH of the intervention group, aka the people who got the alkalinization therapy group with IV vitamin C, was 7.32, much higher pH, right, than that of the control group, which was 6.44. The median overall survival for the people who got alkalinization therapy with IV vitamin C for this small cell, which is known as, again, kind of like pancreatic cancer, known as a very deadly and severe cancer, small cell lung cancer, they lived 44 months. Okay. However, the people who did not get IV vitamin C or did not get alkalinization therapy, 17 months. Wow. Right? Wow. You can see these graphs. You can see them on all of them. You can see the control group less than 7.0 or greater than 7.0. And this one less than 7.0, greater than 7.0. In this case, the control group versus the intervention group. You can see the survival, the overall survival at various times is much higher. You start to see break away at the time when the average is about 17 months for these folks. You can see that it's really drops off the cliff here for the control group, whereas the intervention group was getting much longer survival. And just to let you know that these people were not not doing anything at all, right? These people were getting the standard of care, chemotherapy, radiation, everything they were supposed to get. So did these people. They got the standard of care, plus they got IVC, plus alkalinization therapy, and they lived 44 months on average compared to the 17 months of the control group. This is astounding for a variety of cancers, and it makes a ton of sense. What we're essentially doing is we're shutting down this, or we're effectively buffering this acidosis, so it leads to less ion trapping, so chemotherapy cannot build as much of a resistance, and the immune system can turn back on. Now, imagine if we were doing metabolic therapy in addition to that. My guess is it's going to be even more effective, but I'll digress because we don't have those studies yet. So this was where was it? Here's the small cell with the vitamin C, right? It later says here that all patients who received alkalinization therapy were instructed to take at least 400 grams of fruit and vegetables a day and to not take any meat and dairy products, and then record their daily meals for the first 4 weeks on the start of the alkaline diet. So I just want to reiterate here, okay? These people who lived 44 months were asked not to eat meat, were asked not to eat dairy, were doing fruits even per day, in addition to the IV vitamin C and the alkalinization therapy, and they had results. Do I personally believe that these results would be enhanced if they were not eating fruit and they were on a ketogenic diet in addition to doing these things? I personally believe that because of what we functionally know about cancer. It's going to utilize glucose, and it's going to utilize that to make lactic acid, and it's going to make it to sustain itself and grow and have problems for us. So I don't believe that adding in a lot of glucose is a good idea. But that being said, it's hard to argue with this paper, right? So I'm willing to, say that there is more to the story, clearly, because these people with a very deadly cancer were given upwards of 400 grams per day of fruits and vegetables. And they were not effectively on a ketogenic diet. They were on an alkaline diet, which comprised of a large amounts of vegetables and fruit and minimal meats and dairy products. So just keep keep that in your memory banks. I just want to also say that patients who receive alkalinization therapy receive oral bicarbonate in the amount of 3 to 5 grams per day, and they received IV vitamin C treatment 25 to 50 grams per day every 1 to 2 weeks. I will tell you that again, this is very likely a suboptimal dose, 25 to 50 grams per day per dose, and it's also very likely a suboptimal protocol. But nonetheless, survival was much longer. Now, am I happy with 44 months? Absolutely not. I would love it to be years and years, but still 44 months compared to the standard of care, which is 17 months, is much, much better. So I would say that that's still a step in the right direction. Continuing on, acidic urine is associated with poor prognosis of upper tract urothelial carcinoma. And I will say here that the conclusion was acidic urine is independently associated with reduced disease-free survival and overall survival in these urothelial carcinomas. It's UTUC stands for urothelial cancer of the upper tract. So basically, probably the ureter or even the calyx of the kidney, not actually renal cell carcinoma, further down in the system, but not bladder either. So what you see here again is you see that, and these guys were using pH of 5.5 as the cutoff. Okay, 5.5 is very acidic still, and you can see a difference in the survival for people who either disease-free survival or overall survival was different. Even going from 5.5 or less up to 5.5 or above, you can see survival benefits to those even minimal. Even with still very acidic pH of the urine, you're still seeing survival benefits in these particular cancers, which are horrible. And these people had a poor prognosis. So the next paper is where they're looking at urothelial cancers, same type of cancers, but in the bladder instead of the upper urinary tract. And it says acidic urine is associated with poor prognosis in patients with bladder cancer undergoing radical cystectomy or bladder removal. And it says here, acidic urine was independently associated with reduced RFS and overall survival. RFS, let's see here. I'm not sure what that actually stands for, believe it or not. I have to look and see what that shows, but it's going to be some kind of probably progression, some kind of, like it says here, disease-free survival or progression, reduce progression or something like that. In patients with bladder cancer undergoing radical cystectomy, acidic urine contributing to an acidic tumor microenvironment may promote aggressive behavior in bladder cancer. Let's just be honest, it's every cancer, because these cancers all use Warburg metabolism. They all are fermenting glucose and glutamine. They all have an acidic tumor microenvironment, and they all are going to have a poor prognosis when the urine pH is low. It's a great marker. It's an easy marker. You have to understand. And again, they're using a very low bar here, very low. You're seeing a urine pH of less than 5.5. You can see a lower survival, recurrence-free survival. So basically, survival without any recurrence of disease. And then overall survival also differentiated between the two groups, even with a very, very low bar. Okay. So you're going to see that probably higher is better. And we're going to see it in the case of this particular study. This is the study that I first saw when I was looking at these papers after I saw the initial paper, like this paper here. The first paper I saw was this paper, and I was blown away. So let's start out with looking at this one here. So this one, it seems like this is a big deal in Japan. A lot of these authors are Japanese, and it was done in some clinic in Kyoto, Japan. And it says here that there was basically 36 men and 6 women were included in the analysis. The average age was 64 years. 7 of the 29 patients had extrahepatic metastases. So of the patients, 29 had metastatic disease. And patients were divided into 2 groups according to their mean pH. After the alkalinization therapy, 12 of the 29 patients had a mean pH of 7.0, and 17 had a pH of less than 7.0. The mean overall survival was 95.6 months. From the start of alkalinization therapy was 42.3 months. And I want to just say here that what this paper showed to me was that really higher is probably better. Okay. And I'm going to highlight that in the next one because this one, I'll be very frank with you, it was very confusing to see like how, like what the actual like nuts and bolts were of the actual like paper. This one was published in December 21st of 2023. And it was saying the potential of alkalization therapy for management of metastatic pancreatic cancer, a retrospective study. And they broke it down by pH of greater than 7.5, less than 7.5, but greater than 6.5, and less than 6.5. And again, this is metastatic pancreatic cancer. In general, the prognosis for this particular condition is not very good. Okay, I think most people understand the gravity of having metastatic or stage 4 pancreatic cancer. That you're not in a great position for a long period of life. But I will tell you that this is pretty convincing. So again, same clinic in Japan, but it was a later study. It started between 2011 and 2022. We're including the study. All patients received alkalization therapy, a combination of alkaline diet, bicarbonate, and citric acid administration. Alongside standard chemotherapy, urine samples were collected to assess the urine pH as a marker of whole body alkalization. In 98 patients analyzed, the median overall survival was 13 months. So overall, people got 13 months of life. Let's break it down by urine pH. Patients with a urine pH of 7.5 or greater had a median overall survival by nearly 30 months, 29.9 months, compared to if you had a pH of 6.5 to 7.5, 15 months. Okay, that's kind of where we were seeing. Let's go back quickly here. Okay, let's go back to some of these earlier studies when they were looking at pH of 6.8, right? 6.8 versus 6.3. That's pretty what we were seeing. 16 versus 4 months here. Okay, that was pretty extreme there. The second study they did was 15 versus 10 months. Again, 6.8 versus 6.38. Okay, that's very online with what that study was showing. Basically, if you were 6.3, which is less than 6.5, you had a lower survival, and that survival was 8 months. If you had a pH of 6.5 or less, 8 months survival. If your pH was 7.5 or greater, 30 months. Okay, same treatment otherwise. Pretty astounding results, right? And you can see survival was much longer in these graphics. Further on in the paper, it says the median overall survival from diagnosis of 29 patients who underwent alkalization therapy was 95.6 months, which was markedly longer than the overall survival of 59 months from patients who didn't get alkalization therapy. So they looked at the entire, gambit. And if you got alkalization therapy, you generally lived much longer than if you got the standard of care. Whereas the overall survival from the start of alkalization therapy was 42.3 months. The median overall survival of patients of the urine pH of less than 7.0 was 15.4 months, and that of greater than 7 was not reached. And they're saying this suggests that maintaining a urine pH of greater than 7.0 with alkalization therapy may have contributed to the extension of overall survival. Conversely, the results suggest that urine pH of greater than 7.0 is achieved with alkalization therapy, the treatment may not be effective. So what they're essentially saying is that this is not a one-size-fits-all, because for some patients, if their urine pH is greater than 7, there may not be a huge benefit from doing this treatment. But if your urine pH is less than 7.0, it means that there likely is a huge benefit for you. So let's kind of take a detour off of these like clinical studies and look at the overall kind of like strategy that one may use when employing this therapy. Okay. So this is a paper that was titled Meaning and Significance of Alkalization Therapy for Cancer. And it says here that our research aims to answer the following questions. Can cancer be progressed or stopped by changing the body condition of a person with cancer? I think that most of us who are following my channel, who are following others within the integrative oncology space, who are following Dr. Seyfried, we've already made up our mind that that is not really a question that we need answered, but these researchers needed the question answered. Can cancer be cured? If cancer progression can be stopped, what is the underlying mechanism? Theoretical rationale for alkalization therapy. Almost 70 years ago, Goldblatt and Cameron G. reported the idea of alkalinization therapy. Before that, Otto Warburg had been studying metabolism of cancer and discovered the essential nature of cancer. He published a review in Science in 1956 under the original title, An Origin of Cancer Cells. From this phenomenon we described above, we established the theoretical rationale for alkalization therapy based on the question, how does cancer form and what is its nature? Limitations of deductive methods and inductive approaches. In this paper, we describe a method to reconstruct the limitations and weaknesses of the modern cancer medicine as science-based medicine using the inductive method, and present a new vision of cancer therapy. How should we treat cancer? Case presentation. Use a specific clinical case. We present patients in whom were successful treated with no or few anti-cancer drugs. The biggest weakness of the current cancer therapy is that they only treat the cancer and not the actual patient. The alkalization therapy that we advocate does not compete with any current standard treatment, but improves the effectiveness of standard treatments, reduces side effects, and lowers medical costs. I mean, it sounds like a pretty winning strategy here, huh? Okay, so let's dig into the paper. Theoretical basis for alkalization therapy. It says here, in this review, Warburg described the work described above. The implication of this experiment is that the presence of nutrients, but the absence of oxygen causes cancer. What happens when there's no oxygen? Mitochondrial breakdown. Mitochondrial breakdown occurs in the cell. When the mitochondrial breakdown occurs, cytochrome C is released from the mitochondria and the cell undergoes apoptosis and dies. Warburg et al. Observed that cells maintained under such aerobic conditions, glycolysis was enhanced, aka the Warburg effect, and oxidative phosphorylation was reduced. Thus, what Warburg calls a cell was enhanced fermentation and reduced respiration. In other words, under anaerobic conditions, cells that avoid mitochondrial breakdown and choose to live by glycolysis are cancers. Thus, this activated aerobic glycolysis, which is called the Warburg effect, is a hallmark of cancer metabolism and is known to be common in all cancers. Yes, this is we know. Later, it says, more recently, Seyfried has proposed that cancer is not caused by a genetic abnormality, but is a mitochondrial metabolic disease. He has experimentally shown that the cause of cancer is the cytoplasm of the tumor, not the nucleus. This is also the same proposal made by Warburg. The authors agree with this view and the importance of treating cancer as a metabolic disease. Moreover, cancer patients with type 2 diabetes are known to have a poor prognosis. But we use metformin as needed to keep the hemoglobin A1C levels below 6, preferentially around 5.8. I don't know if I agree with that. Probably the lower is the better, but I'll digress. When cancer starts to live on glycolysis, their intracellular pH is always alkaline. In contrast, the intracellular pH of normal cells is almost always neutral. The cancer cells that live by glycolysis generate large amounts of H+ or protons. They activate a mechanism to expel the protons and keep the cell intracellular alkaline. As a result, the tumor microenvironment becomes acidic. Furthermore, extracellular acidic pH and intracellular alkaline pH in the cancer is known to induce malignant behaviors, to increase invasive invasion and metastases, multi-drug resistance, suppression of the immune surveillance, etc. One interesting example of this was reported in human lung cancer cell experiments, where a 0.4 increase in the intracellular pH was associated with a 2,000-fold increase in the level of doxorubicin resistance in the tumor. So what is it actually saying is that not only is the tumor microenvironment outside the cell very important, and I've seen this in other publications as well, but this is just one that I highlighted, is that for every 0.4, the pH goes up inside the cancer cell because it's removing all the lactate, clearing it all out. It will increase the resistance to doxorubicin by 2,000 times. Pretty interesting. Again, this is in cell culture, but still, it's pretty fascinating. leading to proliferation, metastases, expression of genetic abnormalities, growth factor activation, blah, 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 blah. So basically, the status quo within cancer of having a more alkaline environment inside the cell, an acidic environment outside the cell is problematic. I think we beat that dead horse at this point. Now, what does alkalinization therapy look like according to these authors? Well, it says that the patient should be first advised to change his or her diet. I think that's probably a good idea. It is important to measure the patient's urine daily with litmus test paper. There's the first action step besides changing your diet. Get a urine pH strip, okay, and check your urine daily. Under normal conditions, the urine pH is almost 5.5 to 5.5 is acidic. But as the diet is changed to an alkalinizing diet, fruits and vegetables, no meat, no dairy, again, that's their version of the alkaline diet, the urine pH will increase. The aim is to achieve a urine pH of 7.5 or 8 or higher. And if this is not achieved, alkalinizing agents may be given IV, intravenously, or orally. I think IV makes no sense, if you want me to be honest with you. We give sodium bicarbonate IV in the hospital all the time. It needs to be kind of like monitored by a doctor. You need to have an IV. You need to have someone injecting this into you. I think that is probably a silly way to do this. If you want me to be honest with you, I think oral makes a lot more sense, and it's going to be cheaper and safer and doable for people at home. Okay, going down further. Next steps. The next thing to do is reduce inflammation. Again, according to these authors, next thing to do is reduce inflammation. C-reactive protein, CRP, is used as an indicator. The patient should be taught to keep their CRP less than 0.05. It is reasonable to assume that an elevated CRP in carcinoma carriers is due to the acidification of the tumor microenvironment, where protons present in the tumor microenvironment attract primarily immune cells such as neutrophils and macrophages. So I think it's kind of interesting because there's actually something that Dr. Cruz talks about quite a bit. And he talks about too many protons, not enough electrons being an acidic environment. And that is kind of talked about here, and how too many protons, not enough electrons. Basically, you have you have an imbalance of charges, essentially, which leads to the upregulation of CRP, which is an indirect measure of interleukin 6, which is an inflammatory cytokine. I think that was interesting to pull up. Now it talks about obesity raising CRP, and weight loss could be important, and other things. And they're talking about using intravenous doses of at least 4 grams as being electron donors. I'm telling you, I don't think that's a good idea to use such low doses of IV vitamin C. But I'll digress. We'll talk about IV vitamin C in an entire video at some point. And it says here that the aims of treatment are to have the urine pH of 7.5 or 8 or more, a CRP of less than 0.05, and a neutrophil lymphocyte ratio of 2 or less, 1.5 if possible, lymphocyte count of 1,500 to 2,000 or more. And it says, in conclusion, the treatment we advocate does not conflict with conventional standard therapies, but can be used in combination to increase their efficacy and reduce side effects. So I hope that gives you a little bit of a way of looking at maybe potentially managing this problem. Basically, what someone would do, first and foremost, would be on an alkaline diet. And for me, that makes the most sense to be a healthy version of a ketogenic diet, with the addition of green leafy vegetables as a way to get kind of the alkalinity from the diet itself, while not going hog wild on fruit that will raise your glucose, raise your insulin, and potentially contribute to making cancer worse, because you're going to be pulling metabolic levers that you don't want to be pulling with cancer, needless to say. Number 2, I do believe that getting something simple like these off of Amazon, these urine pH strips, which are like dirt cheap. We're talking like, I think there's, I want to say there's like 125 strips for like, I want to say $10 or something like that. So that would last you, months on end, essentially. Checking your urine pH and just seeing where you're at would be a first step in this therapy. and seeing if you even could benefit from this. My gut tells me that if you have a urine pH of less than 7.5, you're likely going to benefit from this. And I would say most people don't have a urine pH of 7.5 or more, so therefore you're likely going to benefit from this. I will tell you that, reiterating, I have been now being more mindful of a test that we run on every single hospitalized patient called a urinalysis, which has a urine pH as part of it. I'm seeing that a lot of the cancer patients have urine pHs in the fives. And I'm seeing this being a pretty systemic problem. And I'm thinking that most of these patients are likely going to benefit, even if they want nothing to do with ketogenic diet, metabolic therapy, DAWN, HBOT, IV vitamin C, anything to do with metabolic therapy. Just checking urine pH with these ultra cheap strips could be beneficial. Now, the next thing it talks about the use of potassium sodium citrate. I don't like the idea of giving citrate. I've talked about this in the comments with several people when talking about magnesium in particular, magnesium glycinate, magnesium citrate. Even in small amounts, I just don't like the idea of giving it because, as you'll see later on when we talk about fatty acid inhibitors for metabolic therapies for cancer, what we're trying to effectively do is shut down the production of citrate via the blockade of glutamine, but also the inhibition of citric acid related enzymes that help create new fatty acids for cancers. So I'm not a huge fan of using citrate, but I do think the use of sodium bicarbonate could be extremely beneficial. Again, we use this. That's why it has a kidney health, whatever healthy kidney brand, because we use these primarily in medicine for people with chronic kidney disease. That being said, I think it could be a very safe, basically therapeutic strategy for people to use these sodium bicarbonate tablets, which are also ultra dirt cheap, in combination with your ketogenic, alkaline ketogenic diet. And what I'd say is that you probably want to be utilizing these. They come in tablets. They're simple, 650 milligrams generally. And you'd want to use them between meals. You want to use them with your meals because you could, basically neutralize the pH of your stomach, which you need for, the digestion of food. But if you use them between meals, potentially, that could be a good way to do it. And then you're obviously simultaneously checking your urine pH to figure out what the dose could be for you. Please work with a qualified doctor who has a clue about this kind of thing. This is not rocket science. Anybody can do this. You can check your urine pH. Let's say hypothetically you start with like 1 tablet per day of sodium bicarbonate and your urine pH was 6.8. You would maybe go up to like 2, maybe goes to 6.9. You go up to 3, 7.1. Then you kind of titrate up to figure out what your dose needs to be with your diet. But this could be a dirt cheap, easy protocol for anybody to add, and it's going to likely enhance their standard of care treatment, whether it be chemotherapy, immunotherapy, targeted therapies. And if you're going to be on, integrative approach where you're using kind of metabolic therapies with the standard of care, you're going to enhance that. And if you're on metabolic therapy only, you're going to likely enhance that as well. Although I will say that metabolic therapy as a whole, when you're blocking glucose and glutamine, you're already having a large effect on this. I'll be very frank with you. So people who are on a ketogenic diet, maybe who are using, blockers of glutamine, you may find your urine pH is already where it needs to be. But I've had several clients who are on metabolic therapy who have a low urine pH, and I have urged them that I personally believe that they need to be on this sooner than later. And so therefore, I'm kind of telling everybody that I come in contact with that this is going to be probably a big thing for them. This is what I wanted to share. I found it to be extremely important to share with you sooner than later. I even broke the continuity of the current series looking at glucose and glutamine so I could share this earlier than later. Now, let me see if I can get some of these comments. Sodium bicarbonate or magnesium sulfate bathing might possibly be alkalizing skin towards cancer microenvironment? Question mark. The answer is, Ray, I don't know the answer. I would say that whenever in doubt, test. So these urine pH strips are dirt cheap. I'm going to probably buy some for myself I want to test also some of these interventions. And so therefore just test, see where you're at, do an intervention, test, and check it out. It may have an effect. It may not. We'll have to see. Isn't Japan more keto rich than the rest of the world? I don't know the answer to that. I don't know if I can say yes or no. I mean, obviously there's in Asia, there's a lot of like rice and sweet potatoes. So probably not, but I know they eat a lot of fish and seaweeds and things like that. So I don't know the answer to that. I don't think so. Japanese kitchen. I mean, I don't know. I use Hydrion pH strips. Mine is 6.0. Yikes. I think I have. Yep. See, that's one thing. Like, you're going to find out that maybe, wow, I actually need to really get on this. Hot spring water is commonly somewhat alkaline. Yes, I've seen, as a matter of fact, for quite a while, I was drinking a water. It was a spring water that was from Iceland, because I like it has lower deuterium content than water down here closer to the equator. And it had a pH of 8.8. And I would be curious to know what effect it has on my urine pH. I never did any testing, so I don't know. But I would say that it probably does have an effect. And again, I just cannot underscore how cheap and simple and this protocol could potentially be. Again, work with a doctor at implementing these things and making sure it's right for you. But and I would just say avoid around meal times with the sodium bicarbonate, so you don't neutralize the acid in your stomach, so you can digest your foods. But this could be a very, very easy, simple intervention that could have truly life-saving, clinically, very clinically relevant life expectancy, survival outcomes. And I want to make sure that you and my audience have this information sooner than later. So we are going to next be looking at further looking at glucose transporters. We looked at last time the kind of the framework of why we would be targeting these things, what clinical implications there could be with these things. But now we're going to be looking at the actual agents, what they are, natural and drug, of ways of blocking these transporters. If anybody happens to like these videos, please give us a like. If you have anybody in your life that could potentially be utilizing this information, whether it be information like this or information that we've presented over the last year plus, please share it with them. And if you're not a subscriber, please go ahead and feel free to join our mitochondriac army. And I just want to read one more here. Would Natron also work? I'm not familiar with Natron. I don't know what that is. I would like the strips you are showing. I don't have the increments on mine. Yeah, the increments I would say are pretty key, and you want it to be as accurate as possible. As a matter of fact, they're so cheap that you may even want to do 2 at a time just to confirm that that's the urine pH. But once you figure out that they are accurate and they're they have a good quality control, I guess you'd say, then maybe you can just use one. But yeah, I think this is important information, and I hope it's very relevant and useful to you. And until next time.